Yeah, thanks a lot, Bib. When Bib called me to give the keynote lecture at the economics session, I had two immediate thoughts. The first, of course, is that the greatest honor that any speaker can receive is a chance to share his or her thoughts with peers, because these are the people that know you for what you are. So my first thought was I was incredibly honored. The second thought was culture shift, imperative. What the hell does he want me to speak about? And then I realized that this was Alabama fancy speak for change now or face the consequences. That we really in radiology are at a crisis stage, and there are some bad things happening. Now, your first taste of the RLI is whenever there's an academic program, educational program, and a speaker does something other than read films or in addition to reading films, there has to be a disclosure. And I do work with radiology practices, which is why I believe that Bib asked me to speak, because I can tell you from actual happenings throughout the country what we are about to face. And in keeping with Bib's mandate of change, I can tell you what the practice of radiology, I think, will look like in the near future, particularly if we don't change. And I will share with you what the trends are that are influencing what we will do and what we will earn. Now, when most people, when futurists look to the future, they do just that. When radiologists are asked about the future, they seem to be looking backwards all the time. You know, wouldn't it be great if 2015 looked like 29, or better yet, 2005, before the Deficit Reduction Act came into being? Well, it would be great, but it's just not going to happen. Radiology took it on the chin in terms of a wide range of reimbursement cuts, and while many people blame this individual, I would submit that this swamp dweller and great philosopher Pogo was right when he said, "We have met the enemy and he is us." Radiologists, we radiologists, are responsible for many of the problems that are facing our specialty. And if we're to change, if we are to survive and thrive in the turbulent times ahead, we have to understand what those problems are and why radiologists are responsible. Now, Bib said that last year the theme was "Who Moved My Cheese?" and he wanted to extend that to this year. How many of you have read Who Moved My Cheese? Yeah, it's about four critters that are in a maze, and every day they go and find their cheese, that which sustains them, that which makes them happy, and one day they go and their cheese isn't there. And how they respond is the crux of this very thin book. And radiology's cheese has been moved, and radiologists are being forced to confront non-traditional issues. We're being asked to protect against aggressive competition, and we are coping, in many cases, with practice-threatening trends. This is not the time for business as usual. However, last year, 92% of you answered Bib's question about radiologists not changing until the pain of the status quo far exceeded the potential pain of changing. This year, 95% of you feel the same. This is a formula for disaster, because with radiologists, the pain of changing sometimes occurs when the hospital sends out an RFP, a request for proposal for radiology services, and it's too late. Your contract is gone. You can't react to things. You can't wait until the pain is unbearable. You've got to step up. I've got to step up. We've got to step up as a specialty and anticipate the trends in our specialty and develop proactive strategies to deal with them. So what pain are we likely to face? Well, the good news is Bib didn't give me enough time to tell you all the bad news. So of the dozen or so major trends facing the specialty, I'm going to try to focus on 5 key challenges. And those of you that have heard me speak before know that I'm a pretty practical, simple guy. So my aim is to lay out the problems, give you some thoughts about what I think the college should do, and then give you further thoughts, things that you can take back to your own practices and implement so as to better protect you and your practice in the future. So here are the 5 key challenges that we're going to talk about first. Declining reimbursement, particularly impacting the technical component, but now, as you've heard, moving rapidly into the professional side as well. Washington's love affair with family practice and radiology's image or lack thereof. More demands from hospital administrators for increased coverage, better service, and subspecialization. Non-traditional competition for our hospital contracts and outpatient business, and alternative payment systems. So let's start with declining reimbursement. Don't delude yourself into thinking that what we have already experienced is the end of our reimbursement pressures. In my opinion, it's just the beginning. Radiology will continue to shoulder more than its share of the reimbursement pain. How might this occur? Well, that's going to be the job of Bib and the other commission members at this session, but I'll give you at least 5 ways that this could easily occur over the next several years. We might see an increase in the utilization rate, an expansion of the multiple procedures discount, consolidation, further consolidation in IR or CT or MR, the adoption of Medicare or HOPS rates by other third-party payers, a homogenization of regional reimbursement variations, and then, of course, the real biggie, if there's a failure to fix the SGR, that could result in a 30% drop the next time it's due. Now, the second challenge to us is Washington's love affair with family practitioners, the avuncular Marcus Welby, the guy who's out there taking care of the nation's sick. Of course, Washington forgets that he only had 1 patient a week, but that's a different story. Now, I think I could make a pretty compelling argument that we don't need family practitioners, that if you go into the pharmacies or the department stores or the food chains, there are many clinics where nurse practitioners and PAs could rather rapidly and far less expensively triage people to specialists. But what I think and what Washington thinks, 2 different things, and since Washington pays your bills, it's the only opinion that matters. Why should we care? Why should radiologists care? We have to care because CMS, the people that pay us, plays a zero-sum game. That is, if somebody gets more, somebody else has to get less. So if we want to pay family practitioners more, radiologists, unfortunately, are prime candidates to get less. The perception in Washington is that family practitioners are underpaid and overworked. And the perception of radiologists, unfortunately, is the exact opposite. Like it or not, we have an image problem. Who's this? Come on, I'm not going to do this alone. Yeah, this is House. This is House. What role does radiology play on House? Nothing. You're killing me. Bib, go out there and beat them. Nothing. Radiology plays a central role on House. Every week, somebody's getting an MRI, a CT, an angiogram, a guided biopsy. It was a trick question. The question should have been, what role do radiologists play on House? And then the answer is 0. Every study is done by House's fellows and interpreted by them. Geez, I wish I had a couple of partners that were as good as House's fellows in radiology. And that leads to a comment that I made once and has been repeated many times to my absolute horror. Bibb was kind enough not to say it, but I was quoted as saying, the future for radiology is bright. The future for radiologists is far less certain. After hearing Manny Brown's wonderful presidential address, I wish I could say the future for radiology is bright because it is in the hands of visible, committed, engaged radiologist advocates, but then my nose would grow like Pinocchio. We are far from that situation. And the television show House is a metaphor for the challenges that we face. What's this? Anybody know what this is? Come on, guys over there. This is Miami. I didn't come all the way from Tampa not to show you something from Florida. Well, about 4 or 5 years ago, the ACR had a couple of focus groups, one in Burlington and one in Miami. And the topic was radiology and radiologists. What do you think they found out? What did these people say about us? Well, most had no idea who or what a radiologist was. Many thought that the radiologist was the individual who took the pictures. Some didn't even know that a radiologist was a doctor. So if a significant number of individuals don't even think that we're physicians, how long can radiology justify being one of the most highly paid specialties in all of medicine? And how can radiologists be surprised that we took the brunt of the physician cuts? And how can we not expect major cuts in the future? Now, the third trend is very troubling to me because I'm seeing this throughout the country, and I believe it's in epidemic proportion. Radiologists are leaving their hospitals. In some rare cases, it's the radiologists that initiate the move. They say, we are sick and tired of reading 50 indigent skulls, CTs, in the middle of the night. You pay the trauma surgeons, you pay the anesthesiology, you pay everybody but us. We're leaving, they leave the hospital, open an office, and that's the end of it. But that's very rare. What is more common, what is epidemic, is radiologists being displaced from their hospitals. And why is this happening? How can they do this to us? We're such nice people. Why should they do it to us? Well, the first is they're tired of hearing complaints from the referring physicians. So the major reason that radiologists lose their hospital contracts has to do with service and behavior issues. The second is they don't like us competing with them. Now, to me, that's counterintuitive, because if there is an economic opportunity to have an office across the street from the hospital and your hospital doesn't let you do it, what's going to happen? Yeah, your competition will do it. And those patients will be sent, those patients that require further procedures, more invasive procedures, will be sent away from your hospital. But what I believe to be counterintuitive is irrelevant, because for some hospital administrators, this is a very visceral issue. And some outstanding radiology practices have lost their contracts because of competition with the hospital. They want more control, greater numbers of hours of on-site coverage, more radiologists on site, greater numbers of subspecialists. The fourth reason is they want our turf to attract referring physicians. Fortunately, this is very rare to lose your contract over turf. Very common About 90% of radiologists have suffered significant turf encroachment, but have not lost their contract. They want to own our practice, the integrated service model, and we'll talk about that briefly a little bit later in the presentation. Because they don't like us. I don't know what it is about radiologists. We send our most objectionable person, and in some groups there are a lot of people vying for that title, to negotiate with a highly testosteronized hospital administrator, and we expect a positive result. We don't know how to negotiate. We don't know when to negotiate. We don't know what to negotiate. We don't have those non-clinical skill sets. And finally, people are losing their contracts because their hospitals don't believe that the group can provide that 24/7 subspecialty expertise that patients deserve. And there are companies out there that are willing to provide just that. Now, I will tell you that the fourth threat, non-traditional competition, is, in my view, the most pernicious threat to the practice of radiology as we know it today. And unless we are aware of the threat and its magnitude, we are in for a very rocky road in the future. If 75% of radiology is controlled by 3 or 4 corporations in Australia, and I know that's mitigating somewhat, but what's to prevent that from happening here? Previous failures are certainly not insurance against future more successful efforts. What's worse, in the 90s, the old companies were voluntary. You could join Radiologics, you could join Navix, you could join MedPartners, or not. Now, these companies are dealing directly with hospitals, and they're going to take over your contract and seem to have no trouble finding ways to cover even large practices. Manny Brown mentioned one in his presidential speech. I will tell you there's a dozen, and there's no such thing as a good predatory company versus a bad one. The story is the same. The drive is singular. It is to make profit, either to go public or be acquired by a company that's going public, and it will forever alter the way that we practice radiology unless we are prepared to meet that challenge. Manny also used the word disintermediation. Now, Bibb didn't bring me all the way from Tampa, or at least from the Florida delegation, and pay me all these big bucks to speak to you without giving you a big word to go along with it, and it's disintermediation. Who knows what disintermediation means as it affects radiology contracts? Well, yeah, good. One. You're excused. Okay. It means that they're cutting radiologists right out of the equation. Your hospital administrator gets a call. I'll be in Tampa in 2 weeks. Give me 30 minutes to tell you what I have to offer in radiology. And sometimes it's a very compelling message. We have to understand that this is not business as usual. There are several companies that can and will take your contract. And the ACR, which has a forum each year, in 2010 had one on hospital radiologist relationships. And there were presidents of hospitals, CEOs of hospital systems, VPs of radiology. And the message was the same. If all things were equal, we'd rather have our local group. But all things are rarely equal. So what are these companies offering? Well, less or no problematic radiologists. If a problem occurs, that radiologist is gone. We deal with our problems very poorly, and certainly not expeditiously. They provide quality metrics on a monthly basis, 24/7 subspecialty expertise. savings because there's no need for transcriptionists, and probably savings in the future on buying power. Radiologists wishing to maximize their chances to retain their hospital contracts should consider being able to provide the same or better services as those offered by these non-traditional entities. And then there's alternative payment models. By 2015, hospitals are going to be more aggressive in pressuring their radiology groups to become employees, and many radiologists will willingly accept. Why is this pressure coming? Well, some people are saying, oh, profit, but it's really not so much profit. It's the ease of dealing with alternative or bundled payments. How do you distribute the money? Well, it's easiest if everybody's on a salary. If there's money left over at the end, you bonus or put it in your pocket. If there's not enough money, salaries are lower. So these alternative payment models are putting pressure on hospitals, who then put pressure on their associated physicians to become employees. I believe we can do it better. I believe we can accomplish the same thing by staying as independent contractors, and I believe that this is a major role for the college. Fee-for-service has worked very well for radiologists. However, it's clear that practices and hospitals will have to cope with a variety of alternative payment methodologies, whether it's bundled payments, capitation offshoots, ACO options, they're just around the corner. And preparation is going to be necessary if we're going to remain as independent contractors, remain independent from our hospitals. And I believe we can convince hospitals, if we have the data, that it's less expensive and less bothersome for them not to get into the radiology HR business. But the college will have to provide the information that we cannot get on our own. So, this shifts us into the second part. What should the college do? Most everything the college does is important. However, there's a major difference between important and essential. Essential refers to those functions that an organization provides for its members that those members require but cannot do for themselves. In these difficult times, that equates to devoting extensive resources to economics, including health policy research and government affairs. These initiatives are essential for both academic and private practices, and the ACR is the only organization that has a consistent presence in these critical arenas. For example, a hospital president calls a practice chair or president into her office and says, we will be starting a bundled payment project in 2 months. The chair or president, academic or private, should be able to call the college and ask, how much of the bundled dollar is radiology entitled to, and what, more importantly, what is the data to justify that figure? How can we act? If we're to step up to the table, what does that mean? What does step up to the table mean? And I think the college has the resources, and we'll be initiating exciting programs that Bib's going to talk about to provide just that kind of information. But this is a two-way street. In order to do what it has to do, the college needs 2 things from you: your time and your money. And every practice, and that's academic and private, should mandate that all of its radiologists be members of the State Society and the ACR, and that they all contribute to their state PAC and the ACR's Rad PAC. We have a culture where we believe that since we wear the white hats, we're doctors, we're radiologists, we don't have to do anything as unseemly as contributing, paying for our point of view. We better get that notion out of our heads. And being the second best specialty PAC is not enough. Being the first best is not enough. We so severely lag behind people such as chiropractors or trial attorneys that our voice is here compared to here. We've got to understand that it's money that greases the wheels of Washington and our state legislatures, and if we want to be full participants, we have to play by the rules. Also, accreditation to me is the least expensive insurance that radiologists can have to protect against turf incursions. And it sets the quality bar high. All practices should support accreditation programs, and this council should embrace these programs. So, the last part, since I'm a practical guy, I believe that anybody that speaks to a group of radiologists should give the radiologists something to take back. So what should each of you do when you get home in order to best prepare your practice for future challenges and opportunities? So I'm going to tell you what I believe are 6 basic but mandatory things that you should do when you get back home. The first is optimize your governance structure. Make it such that it can facilitate decision-making. Radiology groups have trouble making decisions, and then if by chance they ever make them, they have trouble sticking to them. The difference between great practices and all the rest, to me, boils down to great governance and a great business infrastructure. So in governance, the first thing you should do is have a mission statement and a business plan developed and approved by the group. Both of these provide focus. How do leaders know what to do if there's not a plan there telling them what you want them to accomplish? So the mission statement defines who the group is and what it needs to accomplish, and the business plan then provides the leaders with goals and timelines for their achievement, a blueprint, as it were, for action. Now, the governance model that works best is the corporate model, not the national for-profit corporate radiologist company model, but the corporate model that businesses use. And that's basically a president who interacts with an executive committee. The executive committee usually chairs practice committees and interacts with the practice members. And at least 3 essential committees for practices are finance, operations, and marketing new business. You can have variations, but these important areas have to be considered. Now, I believe that every practice member has an obligation to build his or her practice. And if they're unwilling to do so, then they should be an employee. But it's no longer even sufficient to get practice members involved. It's necessary to get appropriate training for those individuals. And that leads me to the ACR's Radiology Leadership Institute. It is an entity that's designed to provide non-clinical training, starting in residency and ending with retirement, and providing it at multiple levels so that people can participate to the level of sophistication that they require. This is not an entity to service a few dozen individuals who may want an advanced degree. That hopefully will be in place as well, but we need to train our leaders. We need to train our leaders to be, and we need to train people how to be good followers. The military got it right when they said, lead, follow, or get out of the way. We have too many people that fall into that last category. And we need good followers as well as good leaders, and that training is available as well. The second thing is to get your practice documents in order. And here are a list of the documents that you really need to pay attention to. mission statement, business plan, hospital contracts. Some groups haven't looked at their hospital contract for 10 years because it's an evergreen contract. Well, you better be prepared to have that clause challenged and have your contract reviewed. You should know in advance what's important and what's not, what you want to keep or strive for, what you're willing to concede. Your bylaws, your policies have to be in place in a prospective way. And really, your employment agreement is critical. How can you discipline individuals if you don't have policies and mechanisms to do so? How can you deal with your problems? And it's important for the resident and fellow section as well as for the established leaders here of practices that are sitting in the council to understand that these agreements are not contracts of parity. The protections are in place for one reason only, and that's to protect the stability of the practice. No member, old or new, is more valuable or important than the practice itself. And that's why you'll see such clauses as termination without cause, non-compete, and a whole host of other clauses that are designed to protect a practice. The third thing you need to do when you get home is to do strategic planning and scenario planning. Great practices pursue strategic planning, then adopt strategic thinking. They're always ahead of the curve. They employ scenario planning so they can confront problems in a proactive manner. Here are two scenario planning exercises you can take back and maybe over the next year try for your practice. The first is, what steps do you take when your hospital CEO tells you that in the next month he'll be sending out an RFP for radiology services to regional groups and national radiology companies? How are you going to react? It's a lot easier if you've gone through this exercise ahead of time. Second scenario, what should you do when your hospital CEO tells you that she will be participating in an ACO experiment starting in 60 days? How are you going to react? Merely saying, well, I want to be at the table is not enough. What does being at the table mean? What are you going to ask for? How can you justify this? The fourth thing is you need to foster a culture of participation and mutual expectation. Great groups demand that everyone in a practice contributes to practice building. And those activities by necessity occur after routine working hours. You've got to decide whether you're going to be a shift worker or an owner. And this is true in private practice or academics. Nobody washes a rental car. If you own something or perceive that you own something, you take better care of it. The fifth thing is you need to develop and maintain key relationships in your hospital and in your community. To optimize the chances for tenure in your hospitals, you have to integrate your group and each of its members into the medical, the political, and the social structures of your hospitals. Obvious steps include participation on key hospital committees, service as medical staff officers, and the provision of value-added consultations to referring physicians. You've got to develop multiple channels of communication in your hospital, and Bill Fallworth and I were talking about this just this morning. It extends into your hospital at multiple levels. Your practice president and the president of the hospital, your department chair and the VP of radiology, your subspecialists and their clinical counterparts, your department chair and the technical director of the department. And I'm a huge fan of modality champions, subspecialists in your group interacting with technical modality individuals in the hospital. It elevates quality, it promotes efficiency, and most important, it really leads to improved morale. The last thing you need to do is develop a service-first mentality. Great practices want to optimize their financial position, but they realize that if they're going to be successful, money can't be the prime motivator of group members. You can't pay the wrong people to do the right thing. We have to be visible and available. And people say, well, my RVUs will go down if I do consultations or make myself available. Well, you won't have to worry about your RVUs if you don't do these things, because you won't have a job. Radiology is a service specialty. If you're unwilling to accommodate reasonable service needs of patients and referring physicians, you're in the wrong specialty. Provide the service and the money will be there. So, what's the bottom line for 2015? And quite frankly, from what I'm seeing throughout the country, probably a lot sooner. Well, in the old days, all we wanted was to get our slice of the pie. Now we have to understand that the pie is going to be smaller. So to stay the same, we're going to have to get a bit of someone else's pie. And if we want to grow, we're going to have to develop a different type of pie. We've got to leverage our intellectual property, take in new business opportunities in our practice, diversify what we do. In the past, virtually all radiologists were winners, although to different degrees. In the future, there'll be winners and losers. In the past, it took work to fail. Now, I can tell you, some people achieved what was for them a lofty goal. I mean, they were able to fail, but it took work. In the future, it's going to take work to succeed. And now, special word to the RFS. Learning about issues is not a reason to be depressed by them. You made the correct choice. Radiology is the place to be if you're in medicine. It's intellectually challenging, financially rewarding, and the quality of life is difficult to beat. But what we have now is not guaranteed. It'll take work and planning to have a successful practice. The college must take charge of the specialty, and as counselors, we have to make sure that that happens. That's the mandate of the council, and taking charge of the specialty is the mandate of the college. Young people must choose their jobs wisely and take an ownership position in their practices. If we continue with business as usual, there are others who would gladly take what we have, and in many cases they will. We have few friends at the national level. Therefore, we have to play by the rules. PAC's involvement is essential. 13% involvement is embarrassing. We've got to make sure that our partners or faculty colleagues are not taking a free ride on the shoulders of those that contribute. So I'll end by using my Alabama fancy speak and say a culture shift for radiologists is not a luxury. It's an imperative for professional survival. And I'll ask, are you and your colleagues up for the challenge? Thank you very much.